And thank you for the chance to speak in this conference. Thank you, Dr. Soki, for approaching me. And I'm going to try and introduce ECMO. It's a big topic, but because of the short time that we have, I'm going to try and introduce this as a topic. I've titled it Extracorporeal Life Support and not ECMO, and we're going to discuss why that is the case. This is an overview of my talk. Hopefully at the end of this, we'll understand what ECMO is and how it is an integral part of organ support, and also related a lot to kidney support. In terms of the types of organ supports we do in ICU, other than the kidneys, where we do renal replacement therapy, there's a big array of other organs that really need to be working well. As intensivists, we look at the whole body as one big engine, and each of the parts must be working optimally for you to have good results. Looking at ECMO, they are probably, or it's probably important in all aspects of organ support. And even with the kidneys, especially with VA ECMO, where you need to have circulatory support, then ECMO becomes very, very key. My two speakers, especially Dr. Baga, has mentioned a lot about hemoperfusion. We have done a lot of hemoperfusion as well, especially with COVID at the Nairobi Hospital. This is a novel membrane, which is heparin based, and it is called Seraph. And we have done about 24 hemoperfusion sessions with very good results, just as Dr. Baga elaborated. The two words may be used interchangeably, extracorporeal life support vis-a-vis ECMO, but ECMO is more specific to the oxygenation aspect. Extracorporeal circulatory life support encompasses other forms of treatment or therapies where your targets may be different, not just the oxygenation. Here you may be looking at heart failure and management of heart failure, carbon dioxide removal, among others, but ECMO per se looks more into the oxygenation aspect. These are the other forms of life support: intra-aortic balloon pump counterpulsation, ventricular assist devices, and toast to artificial heart. This, of course, will be looking more at the circulatory aspect. ECMO will encompass both the heart and the lung. And the extracorporeal carbon dioxide removal, of course, that is specific to hypercapnic respiratory failure. Looking at ECMO specifically, there is a big difference in terms of the availability of this therapy between the developed world and low and middle income countries. And this map is just trying to show how concentrated this is in Europe, as well as in North America. A little more in South America, but looking at Africa, I think we only have 4 countries or 3 countries. We should be the 4th, and that is Egypt, I think Nigeria, and South Africa. Is it that we do not have patients who require this form of therapy? The answer is no. We have referred a good number of patients to South Africa for this type of therapy. I do remember as a flight physician, I did medevac a patient from Aga Khan here in Mombasa to South Africa in 2016. So what are the basics of ECMO? We are basically trying to do mechanical oxygenation and circulatory support outside the body. It's extracorporeal. We know there has been a lot of development, especially in neonatal practice, more than in adults of more than 40 years. And until the 2000, when we got the H1N1 flu pandemics, we didn't have a lot of use of ECMO, but that has changed over time. And this is because we have had also significant technological advances to both reduce complications and the technicality of this extracorporeal therapy. We have more than 9,000 adults worldwide who have been supported by ECMO since 1990. And COVID-19 per se has caused a big rise in the use of ECMO. We got our ECMO machine at the Nairobi Hospital specifically because of the current COVID pandemic. These are the basics of what happens with the extracorporeal oxygenation. We have an air blender here, which blends air and oxygen. This is how you are able to determine the fraction of inspired oxygen, the FiO2 that you deliver. And then you have the oxygenator, which has a membrane that allows the gas, the blended gas and the blood. And then you have carbon dioxide diffusing out and oxygen into the body. Of course, you have to have drainage of blood from the patient and a return. Looking at it more closely, that's the air blender we have mentioned there, but starting at the beginning, this is the drainage cannula. You have a pump. The pump is able to push the blood to the oxygenator or through the oxygenator. And you have a console here, which is basically a computer that is able to pick a lot of information, including blood flow rates and all that. And after the blood is pushed through the oxygenator, which of course is getting the blended air, then you have a return cannula to the patient. This is a brief summary of the history of ECMO, not necessarily related to the machine itself, but we have other advances, especially in anticoagulation and also in the membrane that have been very important. And this was driven a lot also by cardiopulmonary bypass research and use. And of course, other than the membrane, there were also issues related to the oxygenator, because the initial oxygenators were actually a direct exposure of oxygen to blood. There was no membrane between the two. Dr. Hill did the first adult ECMO. I'm going to show you a picture of that. But later on, with the first successful neonatal ECMO by Bartlett and the establishment of ECMO centers, there was improved survival and other forms of extracorporeal therapy, such as carbon dioxide removal, also came into the fray. The ERSO registry, Extracorporeal Life Support Organization registry, was started in 1989. And this is important in not only developing guidelines, but also keeping track of what are the outcomes of ECMO. By 2001, we had about 120 centers worldwide. That should be over 380 now, which is a big improvement. This is the first ECMO circuit. Unfortunately, man was not very good to man's best friend, and the dog was the first couplet of this. This, of course, did not go too well. The dog eventually died. This is the patient that was managed by Dr. Hill. You can see how cumbersome the whole setup is. This is the oxygenator, of course, with a very big reservoir, probably similar to the cardiopulmonary bypass. And this, of course, had lots of complications if we imagine what we have been talking about in regard to extracorporeal therapies. The modern circuits are much more sophisticated. This is the setup similar to what we have. And even doing therapies, you can do these therapies with patients who are fully awake and are able to, do other forms of therapies, eating and all that. So this has, of course, improved the outcomes greatly. This is what we have now at the Nairobi Hospital, just to describe the components. That is the monitor. These two are the consoles. we always have two, such that if one fails, then you have a backup. This is the coolers for temperature regulation, also very important to have two. We also have two motors. This is where we put the pump. And the pumps we use now are magnetic, levitating magnetic technology, which has very, very little hemolysis as a complication. This is just a description of what those different organs are. And just to add, there is an additional intra-aortic balloon pump and CRRT. This is just to show the kind of sophistication that we have gotten into in terms of organ support. It's not just the kidney, but we are also looking at supporting the heart using the balloon pump, and of course the ECMO per se. There are other more compact ECMO systems. I think the Mackay is the most widely used. This is the whole machine as compared to what I showed you. And this is the oxygenator there. This is important, especially when we are talking about moving patients who are on ECMO, and also something else that we will discuss, which is resuscitation ECMO or ECMO CPR. MIDOS is also another fairly compact system. So there are significant differences between ECMO and cardiopulmonary bypass. I will not go into the details of all this, but just important to note there are differences with the pump. These are not centrifugal when it comes to the cardiopulmonary bypass. And then the oxygenators are different, even in terms of the targets, anticoagulation targets. Our targets are at least 160 to 200 as compared to much higher targets with the cardiopulmonary bypass. And we do not have a chance to auto-transfuse, and that is because we do not have an arterial filter. Just a description of the types of ECMO, and this is in relation to one, what is the aim of doing the ECMO? And then two, how are you going to access the blood, and how is the return to the patient? The first is veno-veno. It means both the drainage and the return are in the venous. This is also what we call respiratory ECMO. And then the two veno-arterial, peripheral and central, this is more for heart support, although they also do significant support to the lungs. Arteriovenous support is probably just a description of what is called the novel lung, which I'll show you. And this is gaining a lot of traction now. The FDA has approved this for prolonged extracorporeal membrane oxygenation. This is a central VA ECMO where the drainage and the return are to the main vessels. This is commonly used after cardiac surgery, especially for patients who have had challenges reversing from cardioplegia, and to the vena cava and to the aorta. That's the access and the drainage. The peripheral one, we are using the femoral veins on either side. Remember, there are many challenges related to cannulation, especially on the vena, on the arterial side, and the fact that you have to create a small kind of bypass so that the blood still flows to that lower limb so that it doesn't become ischemic. Most cannulas that are inserted in the femoral artery do come with that as a precaution. The veno-veno ECMO, which is the respiratory one I mentioned, it can be central. Sorry, this is still peripheral, but can be closer there to the heart or down with the femoral veins where you have the cannulas on each of the femoral veins. But with this particular one, this is where you have what we call the Avalon cannula, which has two holes, one that drains into the right atria and one that goes right into the inferior vena cava to drain the blood. This avoids recirculation. Easier to use, but difficult to insert because you have to use fluoroscopy for this. And this is just a better description of that, or pictorial description of that. This is the arteriovenous option I mentioned. And here you do not have a pump, you do not have the monitors and all that. What you have is just an access from the artery. It's going to the vein, and there's no pump. So the blood just flows through the pressure generated by the patient. This is, of course, assuming that the patient has very good cardiac function. These are the potential pathologies we can treat with ECMO. You can see there are lots of respiratory related, but also other organs. And some of these lead to multi-organ dysfunction syndrome that Dr. Berger described. Also with the overdose of drugs such as tricyclic antidepressants and cardiopulmonary bypass failure reversal. That is very, very important. Looking a little into the respiratory ECMO, which is probably most important in view of the current pandemic. So this is just a description of ARDS as per the Bahrain definition. And where we are looking at using ECMO is when we have severe ARDS. This also describes clearly the kind of interventions we will have for our patients with ARDS, from non-invasive ventilation, and as the severity of injury increases, then ECMO and other extracorporeal therapies become important. Don't forget that recruitment maneuvers such as prone positioning are also very important, and the use of high PEEP and low tidal volumes. These are the indications in terms of using respiratory ECMO. They are not exhaustive. There are even more, or there's even more description of indications and contraindications with COVID. But this is general indications for the use of adult ECMO, and 16 years is a cutoff for using adult ECMO. The Mali score is very important because this is a measure of the severity of lung injury. And then in terms of contraindications, some are absolute, others are relative. Intracranial bleeding is absolute. One, because of the bad outcome that comes with that. And then also, this is not a patient you're going to anticoagulate or heparinize. And then patients who have been ventilated for more than 7 days tend to have very poor outcomes. This is the first trial that gave the impetus to the development of ECMO. And this was just looking at the survival at 6 months for those patients who were randomized to get ECMO vis-a-vis those who didn't get. And this was 63% against 47%. Something else that was very important, that is the Mari score I mentioned, and looks at the chest X-ray, looks at the PF ratio, the PEEP, and also lung compliance. Most ventilators are able to give you this as a calculated measure of other parameters. I wanted to mention the most important aspect of having a referral system and having centers of excellence with this kind of therapy. And the UK is a good example of how this can be achieved. After the H1N1 flu pandemic, they set up these 5 centers. And these centers were all going to receive patients from all over the United Kingdom. And they were distributed in a geographical manner such that all areas are covered. At the Royal Papworth, where I trained, they used the same as we are using, and they have graciously accepted to partner with us in establishing a good ECMO service at the Nairobi Hospital. The mortality was much lower, I think 52% against the 23% for those who did not receive ECMO with a similar disease profile. In terms of commissioning ECMO, which is what we are doing now, these are some of the guidelines or recommendations by the Extracorporeal Life Support Organization. The ability to have a retrieval from other hospitals, that means we have to be able to move with our machine to retrieve patients who are not at our hospital. We have that in place. And also having the ability to do cardiothoracic surgery. Audit and service development was very important because these patients, if you look at infection control, for example, they require more attention than our usual patients. These are the other aspects to consider. Costing, we have done our costing and we know it's expensive. We have, however, a big number of international covered patients covered by the international insurances, including from the UN, and this has given us at least a leeway to establish the service with that assurance. It's resource intensive in buying the equipment that was also covered. And then we looked at an ECMO brand that is more versatile and that we are able to get consumables easily. In terms of staffing, we have looked at all this and we have the array of specialists that is required for that. We have, however, had training conducted in our hospital, most recently in August, and we should be ready now to have our first patient on ECMO. I should mention that ECMO does not treat the underlying pathology, and the aim of ECMO is these three: bridge to recovery, to decision, or to transplant. This is a patient who was saved by ECMO and was able to get a lung transplant. ECMO with resuscitation has also become very important, what we call ECPR, and the outcomes, especially in terms of neurological outcome, have been shown to be much, much better. 28 at discharge, 18 vis-a-vis 12 and 9.7, compared with those who didn't get the ECMO. I'll skip that. Allow me to mention a few words on ECMO and COVID-19. And as I said, this is the reason we got our ECMO. The number of patients who have gotten ECMO has increased tremendously. I'll show you that. But there was initial guidelines by the ELSO, Extracorporeal Life Support Organization, in 2020. They updated that in 2021. And there's not much difference. It looks at these most critical aspects of how to maximize the benefits, patient safety, staff safety, and quality, and also looking at personnel, equipment, among others, including the ethical aspect. This is the number of patients who have COVID-19, all suspected, who have been put on ECMO. And this is the in-hospital mortality, 48%. Don't forget, these are patients whom you are resorting to the last available option in trying to save their lives. And this is pretty good looking at how sick these patients are. This is just a description of how to determine the flow chart of who gets ECMO. They do not have contraindications. They have significant or low PF ratios and other management not working for them. These are the additional relative contraindications. As you can see, such a big and very exhaustive list, including CKD there. So these are patients whose life expectancy is expected not to be too long. The management of patients who are in ECMO, one is to rest the lung. I mentioned this. And these are the lung there are many other aspects, and this is where you as colleagues in nephrology are going to be very important. We are going to have multiple transfusions. These patients may have they may have kidney failure as well, and there is a risk of shining. So this is where you as nephrologists are going to be very, very key. These are the other aspects. I'll mention briefly ECMO and kidney support. There's a lot of evidence to show that, yes, you can use these two extracorporeal modalities safely, both in terms of managing end organ failure and also optimizing fluid and electrolyte balance. I quoted these two reviews that were quite exhaustive. And these are the two ways you can combine ECMO and the filters. The first option is where the blood first flows through the ECMO, gets oxygenated, and then now comes to the hemofilter there, and the blood goes back to the patient. The second one is where you have blood flowing both to the ECMO set and to the CRLT machine concurrently, and eventually out back to the patient. These are the complications. This is my second last slide. And breathing is very important due to platelet dysfunction as well as due to the anticoagulation. We do ACTs by the bedside, fibrinogen levels and all that, so that we avoid that. Thromboembolism, this can happen either due to the catheters, the accesses, or due to a coagulopathy. Neurological, the main one is bleeding, but you can also have thrombosis. And then there are, of course, cannulation-related complications. You can tear vessels and all that. Heat is also very important, and agatroban has been suggested as a good alternative. Then these three complications are more unique to VA ECMO, especially peripheral VA ECMO, pulmonary edema and hemorrhage. These are the solutions: venting the LV or the LA, cardiac thrombosis, usually due to stasis. And this is where the intra-aortic balloon pump becomes important. And then what we call the Harlequin syndrome, where you have blood flowing more to the lower part of the body with very little to the upper part of the body when you have peripheral VA ECMO. And the solution with this is to convert to VA ECMO, where you have a third cannula that pushes blood either to the internal jugular or to the subclavian. I'll leave it at that. I know ECMO is a new therapy, it's a new intervention, but I foresee it being a very important part of our ICU care in the near future. Thank you.
Thank you very much, Dr. Okioma, and a big applause. Thank you. About organ support, it cannot get any better. And there's no organ support system that we have not touched this afternoon. So it's very, very important that we are now talking top of the range in terms of organ support. And our next presentation will be by Dr. Malcolm Correlia. This is a presentation online. Is it ready, or we move to the next one? Hold on your question at the far end of this exposure. There are many questions about organ support that are going to be asked. So we move on quickly.
We're
getting that presentation done. So if you have a patient in East Africa who needs ECMO, then you don't have to go outside the East Africa region. You can get it right here at Nairobi Hospital. And I'm sure as the experience is gained and more centers will be able to access that. And it's our hope that most of our younger colleagues who are training in critical care treatments, either in nephrology, cardiac, lung, can be able to be exposed to ECMO, so that at least they don't have to read it completely now that it's available here within our region. As we set up, be writing your questions at the end of the presentation. We're going to have a couple of questions. We're still on time. I want to recognize my co-chair, my boss, Dr. Witi from Kisumu, is keeping the time very well. I will be taking over shortly. How far are we now? He's saying 1 minute. So 1 minute, we can stand once more. Now this is our last exercising episode. Just stand, turn around like this. Okay. Stand. Secretary, stand. Turn around. Continue turning until I tell you stop. I know the vestibular system, so I will not induce dizziness. Okay, stop, stop. Don't fall down. Okay, we can now settle down as we set up this system,
which is active removal of fluid,
So Dr. Cornelia Malcolm is a physician, a nephrologist, recently qualified from East Africa Kidney Institute. Is currently working at the Nairobi Hospital, where they are participating with Dr. Okioma in critical organ support systems. So he's going to speak to us, a recorded system, on a very important topic on the 4 Ds of fluid management in critical care. Fluid is actually toxic or life-saving. We're ready. Thank you.
Good afternoon. My name is Dr. Malcolm Correa. I shall be presenting on the 4 Ds of fluid management in critical care during this wonderful conference. I have no significant disclosures to make for this presentation, and I want to dive right into the acute care medicine resuscitation principles, which are to stabilize the patient, look for and reverse the cause of shock, as well as do no additional harm. Some terms to remember: early goal-directed fluid management, which would be about 30 mils per kilogram of fluid within the first 3 hours of management. Then late conservative fluid management, which would be to try and achieve 2 days of negative fluid balances within the first week, and a late goal-directed fluid removal, which is active removal of fluid with even renal replacement therapy or diuretics, with de-escalation and de-resuscitation in mind. So why do we give so much fluid? We have many reasons which have been given over the years in terms of looking at different losses from patients, maintenance, nutrition, pre-op fasting, blood loss. But is this truly the reality? And in the study done in 2018, looking at over 14,600 patients who had a cumulative ICU stay of over 103,000 days, but a mean duration of stay of 20 days, we found that only 6.5% of patients were given fluid for resuscitation, 24.7% for maintenance, and 33% in nutrition, leaving a very large, almost 33% of patients given excess amount of fluid, which was due to fluid creep. And fluid creep came up from acute burns patients, which ended up having excess amount of fluid, which was not catered for, and it came from medication and electrolyte concentrations. So where did it all begin? The early goal-directed therapy came from the study done by Rivers, and essentially it showed that there was a reduced mortality significantly by giving early goal-directed fluid therapy. There was controversies because initially this was done on small scale in single institutions. Then large trials came up, which is the PROCESS trial, ARISE trial, and the PROMISE trial from the US, Australia, and UK respectively, and looking at protocolized management of fluid management. And if we look at the PROCESS trial, 1,300 patients who were given protocol-based and early goal-directed therapy or protocolized-based standard therapy, which did not require the placement of central venous line catheters or administration of inotropes or the blood transfusions, versus standard care. Basically, at 90 days and 1 year, mortality was more or less similar among the different groups, and there was no need for organ support. And this was reported also in the similar, in the ARISE and the PROMISE trial. But what is important is also measuring the lactate level, targeting the SVO2 levels, and the central venous line were not very associated with improved outcomes. But there was more a direct, aggressive, individualized care towards patients getting blood cultures of urine and cultures of sputum as well, directing antibiotics towards the correct treatment and getting blood pressures restored, as well as reversing evidence of end organ perfusion, which basically came up to the different requirements of our acute care medicine principles, which would be to stabilize a patient, reverse the cause of shock, and then do no additional harm. But when we look at these 3 studies which were done in sub-Saharan Africa, there was grossly the agreement that giving large fluid boluses in resuscitation in patients with septic shock was a problem, and it led to higher mortality. And which brings into question the amount of fluid which is required in terms of fluid boluses. So when we look at fluid overload, treating a patient with septic shock inevitably leads to fluid overload. And this is because of salt and water retentions. And this comes from initial fluid resuscitation with all the right requirements of why we're doing initial fluid resuscitation, as well as the administration of large volumes of fluid for where we don't count it in terms of drug diluents, artificial nutrition, as well as maintenance fluids. And basically this leads to capillary leak, and which is an inherent maladaptive problem of sepsis, which leads to interstitial edema and give organ dysfunction and eventual failure. So how do we calculate the fluid overload? You take a cumulative balance divided by the patient's body weight as a percentage, and the cutoff by very many studies has been about 10%, where going above this value would lead to worse outcomes. So how much harm does a fluid overload do? And this diagram basically shows us that every organ is more or less affected with increased abdominal pressures. You get respiratory effects, and in the kidney, it leads to more salt and water retention, uremia, and a lower GFR. This can lead us to going into preemptively or requiring renal replacement therapy. And what is also known about fluid accumulation is that global increased permeability syndrome can occur, which is seen in patients with persistent systemic inflammation or ongoing transcapillary albumin leakage, and it leads to increasing positive net fluid balances. It is essentially the third hit of shock after the initial insult, and then we have ischemia reperfusion therapy. So when we give a hypovolemic patient fluid in terms of resuscitation, it could end up in interstitial edema with visceral swelling, increase in intra-abdominal pressures, which again, when we compress on the intestine, leads to mesenteric vein compression, venous hypertension, giving hypovolemic shock, needing resuscitation again. Or it could press on to the kidney, and this leads to oliguria and makes us want to give more fluid. So how do we get around this? How do we make forward for a breakthrough? And we have to borrow from stroke care. And here in stroke care, we have the 8 Ds towards stroke care. And you look at detecting the stroke, dispatching EMS, delivering the patient to the door of a stroke center, and getting a rapid triage evaluation done for management with a decision of whether we have the therapy available or not, and which drug is going to be used. And then after that, is this patient being disposed to a stroke unit or the critical care department? And basically, when we look at this, we borrow from it, and we treat now fluids as basically using a 4D approach, which says detect the fluid requirement, but treat it as a drug, look at the dosage which is required, the duration of the fluid, and then aim for de-escalation, where you reduce, remove, and rethink the need for that fluid. So when we treat fluids as drugs, we can look at normal saline and say there's nothing normal about it, where you would end up giving in every liter of fluid 3,500 milligrams, which is more than the daily requirement of most of our patients. And looking at this analogy, essentially 1 liter looks to be 20 bags of crisps. When we look at fluid as drugs and we treat them as such, when we give this to our nurses, basically they are quick to do a drip factor and a drop factor in order to tell us how much fluid is required in 1 day. So when we treat it with the appropriateness of therapy, if we don't, we can lead to hyperchloremic metabolic acidosis, which can lead to more AKI and more need for renal replacement therapy. If we make it appropriate therapy, then we consider the patient's risks, take into account fluid balances, fluid overloads, capillary leak, and other organ function. We also look at what kind of fluid is being used, and then we're checking if this is hypo or hypertonic fluid. We're looking at the glucose within it and its direct impact on the acid-base balance, as well as cellular hydration and electrolyte regulation. we have to look at the timing. If there's refractory shock, we can't keep giving fluids. We go for vasopressors in order to improve microcirculatory hypoperfusion. And then we look at the route. If it can be given orally, we move for oral versus intravenous. And then now we look at the big 5 questions at fluids. So when do you start the fluids? When do you stop the fluids? When do you review your prescription? When are you going to start removing the fluids? And then when are you going to stop removing these fluids? The indications we have for fluid therapy, as we've seen before, are basically grouped into resuscitation, maintenance, replacement, and nutrition. But we are aiming for a combination of these. And when we look at it as resuscitation fluids, this is done for saving life. And in this paper, which was done looking at fluid resuscitation within patients who have end-stage renal disease, whether they were to be given the 30 mL per kilogram compared to non-end-stage renal disease patients, we find that the base of having end-stage kidney disease, 104 patients versus 111 patients in the control group, 23% received 30 mL per kilo versus 60% in the control group. And this shows that there was already a limitation in how much fluid was given to patients with hemodialysis. The average amount was about 2.21 mL per kilogram versus a control group of 36 mL. And looking at ICU requirement and vasopressor need, it was actually less in the end-stage kidney disease group, who actually received less fluid, and as well as the intubation rate was less. But when we look at the length of stay, mechanical ventilation days, overall mortality, and the requirement for fluid removal due to overload via dialysis, it was all more or less the same. And the author's conclusion of this study was that the initial fluid resuscitation of 30 mL per kilogram may actually be safe, or at least not harmful, even in patients with end-stage renal disease on hemodialysis, and it can be incorporated into the bundle. When we look at maintenance fluids, we're looking at it for its daily requirements, covering the daily requirements of potassium, sodium, and sugar, so that we don't cause starvation ketosis. When looking at replacement, we have to take into consideration gastrointestinal losses, high output fistulas, and then nutrition-wise, we have to look at the calorie requirement, taking into account that patients will now require more calorie due to catabolic events as well as losses. When we look at dosing the fluids, we're looking at their pharmacokinetics. What is the type of fluid you've got, its distribution, the pharmacodynamics, as well as the toxicity that we have already explored with heterostructures. And keeping in mind that colloids, almost 100% stays in intravascularly versus D5 water, which only 10% stays intravascular. When you're looking at the type of fluid to choose, whether the patient has had surgery or whether the patient has had trauma, whether it's patients having fluids in sepsis or in the ICU, the main point here is looking at a balanced strategy, a fluid strategy, which is the most important. The duration is the appropriate duration. We don't know. It's controversial. There's no consensus today to this. And the basic thing is to treat the response and looking at preset targets to be met with things like resolution of shock. And the longer you delay in administering fluid, the more there is more high microcirculatory hypoperfusion and more ischemic reperfusion injury. In the study done by Murphy, he looked at compared outcomes of early adequate versus conservative versus late conservative versus liberal late fluid administration, and found that combining conservative, the early adequate goal-directed therapy and the late conservative fluid management had the best prognosis. This is where we bring in the ROSE concept, where we have a resuscitation organ and stabilization support phase, which is the second hit, the third hit from the evacuation and removal of fluid, as well as this de-resuscitation, avoiding hypoperfusion, which can be the fourth hit. So we're looking at rescuing, optimizing, stabilizing, and then evacuating of our excess fluid. In the resuscitation phase, we're looking at patients who will have come in with the first hit from sepsis, pancreatitis, burns. And we're looking at the need for a fluid bolus versus a fluid challenge versus predicting the fluid response. And this is where we look at sepsis having an ebb and flow phase, where in the ebb phase, it is the secondary to vasodilation, reducing systemic vascular resistance, and giving increased capillary permeability, leading to a flow phase where patients may mobilize their fluids, similarly to the polyuric phase of AKI. And innate immune response is activated, so the metabolic demand increases and increased oxygen consumption is also required. When we look at the actual response we have, we measure the lactate levels. We obtain blood cultures before administering any antibiotics. We begin rapid administration of 30 mils per kilogram crystalloid and hypotension or a lactate above 4 millimoles. We give vasopressors if hypotensive or during and after fluid resuscitation to maintain a mean arterial pressure of 65. And finally, we measure the lactate level if it's above 2 millimoles. And now we want to know, how do we predict the fluid responsiveness? And basically what we have seen is that in the FINIS trial, that 59% of cases received fluid boluses to treat hypotension. But we want to know that fluid responsiveness can only be defined as an increase in cardiac output after a bolus, possibly about 10%. And this elusive fluid bolus, when we ask different people, physicians may say 500 to 1,000 mils, some cardiologists may give us 100 to 350 mils. In this study, basically, which took up all the different types of ways of checking fluids in their hemodynamic effects, the minimal fluid volume that is able to increase backward pressure and venous return is 4 mils per kilogram, and given over a period of like 10 minutes is what would be constituting an actual fluid bolus. When we're trying to optimize, we're looking at a sicker patient getting more organ dysfunction and requiring more fluids. So how we can get around this is by using the passive leg raise or the end expiratory occlusion test before we give fluids. And this is how a passive leg raise is done, essentially putting the patient in a semi-recumbent or to a horizontal position and lifting the legs up 45 degrees and looking for a cardiac output of 10%. In the end expiratory occlusion test, which can be done still in this era that we are going through with this pandemic, you stop mechanical ventilation at the expiration phase for about 15 seconds and look for a cardiac output of about 5% increase. In the stabilization phase, you're focusing on the shift of organ support to recovery, and the fluid shift has to be from replacement of losses. So when we look at a fluid balance, this is the sum of fluid which is taken over 24 hours, and a cumulative one is over a set period, let's say like 7 days. And what we've seen in this study by Macedo is 2.7 liters by day 2 to 6.5 liters by day 7 leads to 25% of patients meeting the criteria for progression into AKI. Finally, we look at evacuation and de-resuscitation. It usually occurs days to weeks after the initial insult, and it can be the third hit due to the GIPS, and this phase is for de-resuscitation. The late goal-directed fluid removal, where you aggressively use diuretics or ultrafiltration, discontinuing fluids when they're not needed, and transitioning to a negative balance. And this late conservative fluid management is a moderate strategy aiming at no fluid overload with 2 negative fluid balance days within the first week of ICU. Our take-home messages for this is to treat fluids as drugs, looking for the indication, the dose, the duration, and when to de-escalate. Avoiding fluid overload and the impact it has on mortality, length of stay in ICU, as well as ventilatory days, with a cutoff of 10%, making these issues worse. And finally, looking at the concept of rescue, optimizing fluids, stabilizing, and then de-resuscitating. Thank you very much.